Okay, thank you very much. So, welcome to Dr. Helen Cohen, who I've known for a few years. She is a consultant rheumatologist and specializes in obviously rheumatology and chronic pain. And she's going to be talking to us today about the potential of developing veterinary rheumatology as a specialty. So, over to you, Helen. And also, just to add, you will have opportunity to ask questions. If you just pop them in the chat, and we will cover them at the end of the session. So over to you.
Thank you very much indeed, Ava, and thank you, everyone. It's a real pleasure to be able to speak to you today, talking about the potential for human medicine and veterinary medicine to be really working together much more collaboratively. And an area that is absolutely ripe for this is rheumatology. So I'm going to talk about what is it that we do in human speciality of rheumatology, and then just give a very brief overview of some of the scope of the rheumatic disease that is common to both of us on the human and the animal side of medicine, touch on the clinical and research relevance, and then just finally round off with how might we be able to establish veterinary rheumatology as a speciality. So what is human rheumatology? The answer is it's changed. I'm greater than you think. And from when I first started in rheumatology, we did musculoskeletal and soft tissue disease. Rheumatologists also dealt with all the autoimmune inflammatory arthritides. So that's things like the rheumatoid arthritis, psoriatic arthritis, lupus, anything that basically was autoimmune driven. More recently, we're starting to develop expertise in autoinflammatory disease, and this is a more recently recognized entity, as well as degenerative joint disease, but also rheumatologists used to deal with rehabilitation, sports and exercise medicine, and because of the speciality you were in, pain management. Now, the modern rheumatology has rather split off the rehabilitation into a separate speciality in human medicine. Sports and exercise medicine is also splitting off as a separate speciality, and pain management is again a separate entity. So I'm a little bit unusual in that I cross so many different specialities. So the modern rheumatologist for humans is becoming increasingly an inflammologist. So the focus here is on autoimmune disease. So this is those diseases where the immune system is targeting the body and different areas of systems within the body by mistake. And the modern era is run by biologic drugs. These have been complete game changers for conditions such as rheumatoid arthritis, cancer, and the list keeps growing. And particularly, it's the monoclonal antibody drugs. So this is where you take a specific immunoglobulin antibody and you target it very specifically against a protein, and that might be on the surface of a receptor, it might be against a specific protein, and because it's an antibody, which you develop by cloning in a hybridoma cell, you can target it very specifically. Now, in rheumatology, we've often targeted against cytokines or cytokine receptors. And cytokines are those proteins that the body produces that are the orchestral conductor, if you like, of the whole of inflammation and how inflammation works. So if you can target a key cytokine driving an inflammatory pathway, you can switch off that inflammation. And this is what has been such a huge game changer for rheumatoid arthritis, which has gone from being an irrevocable, progressive, destructive disease that we could do very little about to being able to halt it in its tracks. Now, originally, the early monoclonal antibodies were actually raised in mouse cells. So some of our early monoclonal antibodies, we could have allergic and anaphylactic reactions. But as technology's got better, we can humanize the antibodies, we can pegylate it, which is another way of making it less make it less likely to cause an immune reaction. But we still do use mouse-derived biologics, and the architect of this is infliximab. This was the first ever anti-TNF monoclonal antibody that we used in human beings for rheumatoid arthritis, and we still use it. But as alongside of being able to humanize them, you can actually also species specify monoclonal antibodies. You can canonize them for dogs, you can felinize them for cats, and we'll be touching on that later. So what is out there already in terms of veterinary and human collaboration in terms of rheumatology? Well, this paper was from 2010 and was looking at comparative rheumatology. What can we learn from naturally occurring musculoskeletal disorders in domestic animals? Now, for a rheumatologist, this is actually a little bit orthopedic. So in this particular paper, it talked about hip dysplasias, cruciates. There's a very brief mention of canine rheumatoid arthritis, and it talked about tendons and stress fractures. So from a rheumatologist's perspective, this is actually a little bit more orthopedic. But there were some useful and relevant key messages here that naturally occurring musculoskeletal diseases in animals does provide insight into the process in humans. It also mentioned that pedigree dogs can be a rich resource because of that inbred population. You have some aspects which are more common in that population. And again, you can correlate that to the human area of medicine as well. And canine and equine athletes were also providing models for athletic injuries that you see in humans. So let's talk a little bit about more the scope of disease, so human rheumatic disease and veterinary equivalents. And from everything I've seen, I don't think I found a single human rheumatic disease yet that there wasn't a veterinary equivalent for. On the non-inflammatory musculoskeletal soft tissue side, as we already mentioned, some of orthopedic stuff does overlap with rheumatology. And obviously, where I am working at the Royal National Orthopaedic Hospital, I'm working absolutely surrounded by orthopedic surgeons. So I work in close collaboration. So yes, we do see patients with cruciate injuries, tendinopathies, and bursitis. But there are some interesting differences. Now, as a background, I actually originally wanted to do a degree in human medicine and veterinary medicine and specialize in zoonotic disease. And my father's a retired vet, and my sister is a human physiotherapist who went into animal physiotherapy. So I still have huge links with both veterinary physiotherapy as well as veterinary medicine. And one of the interesting things I've seen is, for example, in humans, we don't use hyaluronic acid for tendinopathies. Whereas I know in veterinary medicine, and particularly in equine medicine, when you get chronic tendinopathies, hyaluronic acid is actually quite commonly used. So straight away, here's an interesting difference. And is there something we can be learning from each other? We see stress fractures and sports and exercise medicines. As I say, we've tended to split that off into a separate speciality. But I know that, again, some vets particularly are dealing with equine athletes and animal athletes. Vets and humans need physiotherapy. And as we've already mentioned, quite often, a lot of veterinary physiotherapists are actually human physios who've gone on to do veterinary degrees. And in some of our non-inflammatory musculoskeletal disease, in human medicine, we use a lot of splinting. For us, it's usually done by our occupational therapists. And again, I know that splinting is also extensively used in veterinary medicine as well. And this is actually a one medicine paper. So this is the overview of spontaneous dog osteoarthritis and how it is very, very similar to the presentations that we see in humans, and that this is a rich resource that we should definitely be collaborating on, both clinically and research. Now, the autoimmune inflammatory side is very interesting. So in human medicine, we have three main areas. Well, we have a lot of autoimmune diseases, but the ones that are big ones are rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, and systemic lupus erythematosus. Now, on top of that, there are a whole range of other connective tissue disease, which are autoimmune basis as well. But in veterinary medicine, I've noticed it tends to be lumped under the immune-mediated polyarthritides, and within that things like rheumatoid and lupus are also recognised. So again, very similar. Now, we would also classify crystal arthropathies such as gout and pseudogout as inflammatory disease, although obviously this isn't autoimmune. And again, I know that there are gout and pseudogout is seen in certain species on the veterinary medicine side as well. This was a fairly recent article about canine immune-mediated polyarthritis, and making the point that it's probably not recognised enough in veterinary medicine, and it's probably a lot more out there than people realise. And the importance for a vet being presented with an animal that has a migrating inflammatory polyarthritis, that as well as the infective side, that the autoimmune side is a consideration. And here are a couple of slides showing the similarities. So on the left-hand side here is rheumatoid arthritis in a dog. So you can see the hallmark of rheumatoid arthritis is erosion and destruction. And you don't have to be a medic or a vet to look at those to go, there's something very badly wrong with that. So in A, B, and C, you can see that those joints aren't aligning properly. You can see the damage. You can see where little nibbles have been taken out of that bone. You've lost the joint space. And in D, it's so bad that it's actually eaten the bone. And on the right are a couple of human equivalents. So this is a pair of rheumatoid arthritis hands at the top. And again, you'll see that same joint malformation. You can see that same erosion, sort of holes in bones where they shouldn't be bone holes. And on the bottom, this is the human equivalent of D on the left. This is what we call arthritis mutilans. So there's a very, very aggressive version of rheumatoid arthritis and another very aggressive version of psoriatic arthritis, where it actually just destroys the joint completely. So you don't have a joint anymore. And that is basically what D is. That is arthritis mutilans, although you might not use that terminology. What about psoriatic arthritis? Now, this is again one of the big ones that we'll deal with in human medicine. And yes, there are a few case reports of psoriatic arthritis. Again, this is in a dog. My strong suspicion is, again, I think there's probably a lot more of this out there than people realize, but they're not necessarily looking for it. So another area ripe for collaboration. How often are vets and vet physios seeing dogs that actually might have a psoriatic arthritis? And the importance of that is most of the drugs that we use in human medicine also are being used in veterinary medicine, and we are now able to treat a lot of these autoimmune diseases extremely efficiently with our immune suppressing and biologic drugs. So if there is canine psoriatic arthritis out there and it's recognized, it can be treated. Spondyloarthropathy is particularly ripe for collaboration, and this has been fascinating just looking around this. And I've known this for a while because every so often people send me pictures of dogs and cats with x-rays and say, what do you think about that? And I've noticed for a long time people sending me pictures of spine x-rays, particularly in dogs, saying, what's this? And it's like, well, that for us in a human, that we call that a spondyloarthropathy, or we call that dish. And looking at the veterinary literature, this is an area that we absolutely have to collaborate on. So spondyloarthropathy, the true inflammatory side that we would recognize in humans, is described in primates, which isn't any surprise. There's a description of it in the brown bear. There are descriptions in dogs, and there are some interesting breed differences. So some breeds are much more prone to this than others. But, and this is what's interesting, we use similar diagnostic terminology, but we mean different things by it. And I think that's a really important area. So I've noticed that, yes, in veterinary medicine, we talk about dish, and that's probably quite similar. I'm going on to that in just a second. But let's often talk about spondylosis deformans. Now, we don't talk about spondylosis deformans. For us, spondylosis means degenerative arthritis of the spine. And some of these images of what is being called in veterinary medicine spondylosis deformans is not what we would call degenerative arthritis. This is something different. And similarly with spondyloarthropathy. Now, there are a couple of papers, same author on both of them, who have actually looked into this in much more detail and goes on to say very clearly that syndesmophytes are not something you see with degenerative arthritis. This is the hallmark of something different. And I'll show you on the slides ahead. A syndesmophyte is when two osteophytes actually become confluent and join. And I've got something on the slide coming up. And the quote here is that syndesmophytes identified underlying arthritis as a spondyloarthropathy, not as osteoarthritis and not as degenerative. But again, the importance here was of recognizing this because it might change how you actually treat that animal. So here are some x-rays of dog spines. And on the top, on the left, we've got a normal dog spine, which is actually very similar to a human spine. Then on the right, on the top right, you can see these spikes of bone where the body does try to repair itself, but obviously it can't do it nice and accurately. So which is why you get spikes of bone, which we call osteophytes. And you can see those spikes of bone. Now that is very similar to what we see in human disease, and that is spondylosis, not spondylitis. But that bottom x-ray here, that is confluent bone, completely across the whole of the anterior aspect of that spine. So that's not going to move anywhere. That is confluent bone, and that is not a degenerative arthritis. That is something different. Now, in human spondylosis, so this is degenerative, this X-ray on the left, again, you can see those very similar spikes of bone. So they can come out, they can almost meet, but they're not confluent, they're not joining. Whereas in ankylosing spondylitis, this starts to join up and flow. And ankylosing spondylitis in humans, we see calcification of the anterior and posterior longitudinal ligaments. That's one of the hallmarks. We can also see fusion of facet joints. And the next slide on again is showing you a severe ankylosing spondylitis. When it gets really severe and the whole spine is basically fused, we call it a bamboo spine. And here again, you can see that there's calcification flowing down the whole of the front of that spine. And that is telling you this is not a straightforward degenerative arthritis. On the top right there, that's a picture taken from one of those papers talking about spondyloarthropathy in dogs. That is a skeleton from a dog with a spondyloarthropathy. So there are some really interesting areas ripe for discussion here between humans and vets. And to take that on a step further, one of the hallmarks of our spondyloarthropathies, so these are our autoimmune inflammatory diseases affecting predominantly the spine, is sacroiliitis. So for us, that is the hallmark of a spondyloarthropathy in a human. For whatever reason, often the first joint affected is the sacroiliac joints. And on the left here is a human X-ray showing that what we see is the joint actually starts to fuse. You get sclerosis. It starts to fuse. You can't see that joint so clearly anymore. And sometimes we get erosions because you're actually getting damage and erosions in that joint. So there are very clear X-ray findings of sacroiliitis. And in fact, in humans, X-rays aren't very sensitive. It takes years to be able to see a sacroiliitis causing damage in the joints. You can pick it up much, much earlier on MRI. So in human medicine, MRI is where we go to diagnose inflammatory spondyloarthropathies. Now, on the right, I noticed that looking at the veterinary literature, there's not much written about sacroiliitis, and what there is written about infectious sacroiliitis, so a true infected septic arthritis. And this is a canine X-ray, again, showing that loss of definition of the sacroiliac joint. I cannot see anything in the veterinary literature about an inflammatory sacroiliitis. So is it that it hasn't been looked for, which is my suspicion? And is it that a dog presenting with the sacroiliitis is assumed to be infective? And if you find the bug, great. But if the client doesn't have much money, I suspect you're going to say, look, this is likely infectious sacroiliitis. We treat it with antibiotics and see if it goes away. So there's a major possibility here that there is actually an inflammatory sacroiliitis which isn't being recognized. So lovely area of overlap that we could potentially look at here. Now, this is what we call dish. So here you can see those flowing osteophytes going all down the front of the spine, and that spine isn't going to move very much, and that is canine dish. So this is diffuse idiopathic skeletal hyperostosis, and we see exactly the same thing in humans. And on the right is a human lumbar spine, again showing the same sort of thing. So this is the thoracic coming down into lumbar spine, and you can see that flowing osteophytes that all across the front of that area of the spine. So we have that equivalent. Now that's much harder to treat in humans. We're not very good at treating dish, whereas the inflammatory spondyloarthropathies, we are. Now, vasculitis is another interesting one. This is autoimmune inflammation, but targeting blood vessels. Now, in humans, it's one of the ones we're scared of, and it's one of the ones that we treat in rheumatology. We have very clear classification criteria for vasculitis. So we talk about small, medium, and large vessel vasculitis. We have classification criteria that are constantly reviewed, and every so often they change, and the names change as well. In veterinary medicine, it looks as if vasculitis is recognized, but doesn't appear to be the same level of recognition of the subtypes that we have. And this is where, again, I'd love to get some more collaboration. What is recognized and what is out there yet that hasn't been identified? Small animal cutaneous vasculitis clearly is well recognized. And there are other papers looking at interstitial nephritis, glomerulonephritis, that's in the kidneys, vasculitis in small animals, but mostly being attributed to infectious disease. So again, interesting areas. How much of autoimmune vasculitis is out there, and does it ever get recognized? And do you see the same human systemic vasculitis equivalents in animals? And I strongly suspect we do. We just may not necessarily have found them yet. Now, myopathy is another really interesting one. We see inflammatory myopathies, actually, and for us, again, in human medicine is another quite scary one. Some of the inflammatory myopathies we see are very nasty and need very serious immune suppression and very, very powerful medications. I noticed that myopathy is described in horse and in dogs. And again, there's a paper here talking about a broad spectrum of the inflammatory myopathies. For veterinary medicine, they talk about focal, multifocal, and diffuse myopathies. Canine dermatomyositis is recognized, as well as immune-mediated polymyositis, subdivided into these categories. And you have an interesting entity which has been recognized called masticatory muscle myositis. So myositis specifically affecting muscles around the jaw in dogs. Now, intriguingly, we have something not dissimilar in humans, which is orbital myositis. So for whatever reason, that autoimmune directed inflammation of muscles is directed to the muscles around the eye. And in fact, literally yesterday, I had a human patient in clinic who I'm fairly certain has dermatomyositis. Now, we have some interesting, well-recognized associations with inflammatory myopathies, including tumor-related paraneoplastic presentations. And I'm sure there's a lot, again, we could learn from each other. Autoinflammatory disease is this relatively newer entity. So the more classic autoimmune disease that we see, sort of like the rheumatoid arthritis and lupus, is arising when our own immune system creates antibodies that target different areas of the body. These diseases are from innate immunity. So this is a different pathway and it's antibody independent. And some human examples of autoinflammatory disease include things such as periodic fever syndromes, Behçet's syndrome. And when I looked in the veterinary literature, it is starting to be recognized here as well. So Charpey autoinflammatory disease in Charpey dogs is recognized. So these are usually genetically based conditions. So you can often find a very specific mutation that's causing these syndromes. And just like in humans, it's characterized by fever and inflammation. And most of our periodic fever syndromes present very similarly. There's also a hyperinflammatory syndrome recognized in Weimaraner dogs, and we also have different autoinflammatory hyperinflammatory syndromes as well. So I think keep an eye in the future. This is an area increasingly becoming part of more recognized and becoming more of rheumatology, and I suspect you'll be seeing more and more of it on the veterinary side as well. And then, being an old-fashioned rheumatologist, I have interest in chronic pain, and in veterinary medicine, this has now become a much more mainstream problem now, and there are a lot of vets developing interests in managing chronic pain. A classic human chronic pain entity is fibromyalgia, which is where there's sort of pain everywhere and tactile sensitivity. Do you see it in animals? Yes, I think you probably do. I know that some work's been done looking at pressure pain thresholds in racehorses and comparing them to little fat happy domestic ponies and seeing a significant difference. So yes, I think you probably do see the same. Do you see chronic fatigue as well in veterinary medicine? I'm sure you will have an equivalent. And a whole nother talk for another day is this fascinating other area of my speciality interest, which is complex regional pain syndrome. Now, the human literature states it doesn't exist in animals. I know that that is incorrect, not just from speaking to vets and vet therapists, but because there are 4 case reports that I can find in veterinary literature, 2 case reports describing dogs, 1 case report of a Swiss cow, and 1 case report showing 2 horses with nerve damage, probable nerve damage related CRPS. Now we have human diagnostic criteria which are very easily transferable across to veterinary medicine. So here is another area ripe for collaboration. This is another area that's increasingly becoming relevant to veterinary medicine, and another area ripe for collaboration, and another area of my speciality interest, which is the inherited disorders of connective tissue. And these are conditions such as osteogenesis imperfecta, this is brittle bone disease, Ehlers-Danlos syndromes, Marfan's disease, and these are all inherited disorders where there are abnormalities of collagen and elastin. And the hypermobility aspect, again, in dogs and other small animals is well recognized. So that carpal instability in collies, carpal instabilities and hypermobility in sporting animals. And I've actually spoken before about Ehlers-Danlos syndromes in canines and animals. So there is clearly this is an issue in veterinary medicine as well. And the one or two case reports of animals with Ehlers-Danlos syndromes when they've looked for the same genes. So there are some rare subtypes of Ehlers-Danlos syndrome, and when in the veterinary medicine literature, when those one or two case reports where they have looked for the same sorts of genes, they're finding exactly the same mutations that we see in humans as well. Similarly, there are one or two case reports of Marfan's, and again, they've found the same mutations that we see in humans. So here is another area absolutely ripe for collaboration. So clinical relevance of human and veterinary medicine. Well, we use the same sorts of investigations. We both use histopathology techniques. We use exactly the same techniques. We use the same imaging, possibly some differences in access, but we use MRI, we use CT, we use ultrasound. Therapeutic drugs are often the same or very similar. We both have to employ a multidisciplinary team approach for complex patients. And it's not as simple as doing an operation, there's the rehabilitation afterwards. And I'm often quite jealous of the facilities of some of my veterinary colleagues for rehabilitation compared to what I'm finding in the NHS. So we have lots and lots to learn from each other. And the other thing that's come out of looking at this is there are some areas where we really do need to clarify our diagnostic terminology and make sure we're both talking about the same thing. On the research side, in human medicine, we often have this reliance on using inbred animal models to try and mimic natural disease. But we have huge ethical issues of using simians or mammals, and even when we use in rheumatology. So a lot of the rheumatology research to try and understand inflammatory arthritis was using inbred rats and mice and then deliberately injecting an irritant into the joints to create a temporary inflammatory arthritis, and that is used as the model for human rheumatoid arthritis or inflammatory arthritis. But even the so-called wild type, so normal rat or mouse that's used in research, is so far removed from its real wild cousin. So there are huge issues with our animal models of disease, and particularly with pain models of disease. Geoffrey McGill has written a lovely series of papers looking at some of those weaknesses of animal models for human disease. And a classic one is that often animal group behavior and communication isn't taken into account at all. So in a lot of pain studies, when you're using rat or mouse models of pain, you have a cage of rats and mice. You take one of those rats or mouse, you do something horrible to it and painful, you put it back in the same cage with all its cage mates, and then you take another animal out of the same cage and do the same thing, and you do that over several days, and there is absolutely no account taken of the animal behavior that's going to result from cage mates seeing another cage mate in distress. So there are very clear limitations of animal models, and we should be using much more collaborative model of using spontaneous animal disease equivalent in human medicine. So the human-animal one medicine approach is absolutely the way forward, and use of real-world spontaneous animal disease, because there are so many human to animal lessons. And here is a wonderful example. So anti-nerve growth factor is a particular monoclonal antibody biologic drug. So nerve growth factor is important in both activation and sensitization of pain receptors. So big pharma in the human industry, of course, were very interested. Could you develop a monoclonal antibody drug that would block this particular protein and therefore might help with pain? And obviously, if you could develop a nice, expensive monoclonal antibody for chronic pain in human medicine, you will make a huge fortune. So there were two anti-nerve growth factor antibody biologic drugs being developed in human medicine, and these were tanezumab and fasinumab. And your veterinary medicine equivalents, so these were canonized, is Librela or Bedinvetmab, and felonized version is Silencia or Frunevetmab. Now, and as you'll be aware, these two drugs are being used in vast amounts in veterinary medicine now. However, what has become clear from talking to vet therapists and vets is that the issues that we found with anti-nerve growth factor in humans have not been made available to vets and vet practices. So this is absolutely fascinating. So the human drug trials for these particular drugs were halted twice. The first time was because some patients on the active drug developed rapidly progressive osteoarthritis. Now, this is normally something that's incredibly rare. I've seen it twice only because I've worked here at the Royal National Orthopaedic Hospital. I'd never seen it anywhere else. And this is where an apparently normal, usually hip or shoulder, can go from being a nice normal joint to absolutely destroyed in 6 to 12 months flat. And when you see the x-rays, it's astonishing. You go from a nice round hip or shoulder to just bits, gone, completely gone. So normally this is incredibly rare, but patients on these drugs were developing rapidly progressive osteoarthritis and requiring joint replacement. So the drug trials were halted. Then there were further discussions, and with discussions and enough pharma clout, the brakes were taken off. And the trial started again, but they were halted a second time when there were potential problems with sympathetic autonomic nerves. Further discussions, the brakes were taken off again, but finally the FDA in the US completely pulled the drugs from the market and from further development in 2021, primarily because of this rapidly destructive arthropathy, but also we were seeing a lot of neurosensory symptoms in patients on these drugs. So some patients would develop quite marked allodynias, neuropathic pains. Some of them would be new neuropathic pains, but in other patients that already had a background neuropathic pain or peripheral neuropathy, for some of them it worsened that. Now, early on, when we were still in the phase 3 of these drugs, I actually communicated with the author of the paper highlighted here, which was one of the early ones on the veterinary side for using these drugs for degenerative pain in cats and dogs. And from personal communication, RPOA has not been described in cats or dogs, but I don't think anyone's looking for it. And certainly from having just spoken at a veterinary therapy conference, it was quite interesting to hear that there are now Facebook groups emerging of therapists and vets starting to notice animals on these medications getting funny pain syndromes. And from communication with another vet therapist, I'm fairly certain I've just heard of the first incidence of a rapidly progressive osteoarthritis resulting in euthanasia for that animal. So, and it's fascinating when I ask therapists and vets, they're not aware of this. So here is a classic example of why humans and vets do need to be talking to each other. And then this is another example of when animal models, inbred models, might not actually work too well for us in human medicine. And one of this was the Northwick Park trial. So some of you with long enough memories and old enough will remember this. So this particular drug, it was another monoclonal antibody. It was being developed to be used in rheumatoid arthritis, and it was developed using inbred mouse models. Now, in those days, you used to be able to give a drug that had never been used in humans to more than one person at a time. It still blows my mind to think that we thought that was okay. So for this phase 1 study, the first time this drug has ever been used in humans, they had a room full of eight human volunteers, and they gave all of them the drug. 2 of them had placebo, but all 6 that had active drug were hospitalized rapidly in ICU. Because it became apparent this drug caused what we call a cytokine storm. And so these patients were all severely ill. They did survive. I still see one of the patients from that drug trial who lost he lost the front of both of his feet. So he's got both of his feet. He's only got the top half was gone. It was gangrene, and he's lost most of his fingers. So that changed how drug trials are done. So now you can't give a drug that has never been used in humans to a load of people all at the same time. However, even then, we still have some interesting issues. So the French drug trial in 2016, this was a drug being developed for FAAH inhibition. This is working on the endocannabinoid system. So this is equivalent to our human endogenous morphine system. So our bodies do actually produce morphine, which is why we have morphine receptors, and how our morphine-based drugs work. Similarly, we all have an endogenous cannabinoid system. So we actually do have cannabinoid receptors. And FAAH is an enzyme that that actually degrades cannabinoids. So if you can inhibit that enzyme, you could boost your own natural endocannabinoids. So this particular drug was developed in rat and mouse models. It was tested in rat, mouse, and dog, and then they rolled it out to humans. But within a few weeks, it became apparent there were huge issues when 5 people were hospitalized and one of them died with acute brain injuries. So looking ahead, the human-animal approach and clinical collaboration, I think, is absolutely key. And I'd love to be involved in that. So what would we need to do to develop veterinary rheumatology as a potential speciality? Well, we need interested vets. The interesting discussion there is, would that be on the internal medicine side more than the orthopedic? We'd need some interested academic institutions, and we need to develop those human and veterinary links. I think to start off with, you need a rheumatologist who's actually attending vet clinics, and maybe a vet that's attending human rheumatology clinics, so you can actually get the two brains in the room at the same time, understanding the similarities and the differences that you see, and that way you would develop the clinical experience. You would need good multidisciplinary team links because you're going to need good imaging, and there would be some really interesting lessons to be learned on the imaging as well. You'll need laboratory links and collaboration. So I know that in human rheumatology, we're famous for all our fancy antibodies that we do. Now, I know that most of those are also available in veterinary medicine, but it's sporadic and it's hard to find where, and there may be some differences in how the laboratories are doing those. So again, good collaboration there. You'd want multidisciplinary collaboration, so physiotherapists would be really interesting to work with as well. There's lessons to learn from each other. And potentially looking ahead, should we be developing a UK curriculum, a fellowship for vets that want to do veterinary rheumatology? And that would potentially lead on to developing some international collaborative links. So finally, I'd just like to say thank you for listening and leave you with a big question. Can I collaborate with you? I'd love to. Thank you very much.
Well, thank you, Helen. That was great. I have loads of questions, obviously. So if anybody has any, please do type them into it. I was quite shocked with that example of the sort of the drug development component as well, and that there isn't, because obviously certainly for the human drugs, there tend to be centralized databases where the serious adverse reactions get recorded, so drugs can be pulled even if they on the market. And I'm quite surprised that there isn't sort of even if there is a veterinary equivalent, that there is no sort of linking of the information together, which could be potentially relevant to both, really, on both sides, on the human side and the veterinary side, when things. Because drugs do tend to, once they have been developed and once they enter the market more widely, they do tend to cause problem with the other concomitant medications. So I'm really, really surprised that that doesn't exist. I did have a more specific questions actually around the autoinflammation diseases, because that's one of the areas that we certainly also have been looking in terms of genomics, because as you say, in terms of the spate example of the Shar-Pei dogs and also the Weimaraner, do you think that from the human side, where there is quite a big focus on the precision medicine as well, that perhaps actually closer collaboration and looking at some of these, because essentially, obviously, each dogs in themselves are a very close population, but specific breeds are even more so, that actually collaborating more closely together would identify these specific genetic mutations that could help to develop more precision medicine to treat those in both humans and animals. It's quite a long-winded question, so.
But thank you. You're dropping out quite a bit, Ava, but I could hear most of that. Yes, Definitely closer collaboration. The genomics, there are going to be really interesting overlaps. So I have little doubt that the same, as we get cleverer and cleverer with the genetics on the human side, we're finding more and more of these diseases are autoinflammatory. So Behçet's, it has been reclassified as autoinflammatory, whereas previously it was sort of sat under autoimmune. We weren't entirely sure. The human periodic fever syndromes, every year there's more added to the list as you find more genes. And we know that certain ethnicities are more prone to certain of these autoimmune conditions, autoinflammatory conditions than other ethnicities. So there's your similarity with dog breeds. And we know that for some of these, the consanguinity, so the veterinary medicine equivalent would be inline breeding. We know that you see some of these more often with that. And on the human side, when we've found the specific gene and we know which part of the cascade is the problem, which is what in cytokine or what aspect it is that's causing the syndrome, it's being targeted with the monoclonal antibody drugs. So there again, if you've got that similarity, the human drug that we are using is probably going to be effective on the veterinary side as well. So absolutely, I think there needs to be closer collaboration.
No, that's really helpful. I'm also really, it is quite interesting in terms of obviously the fact that sometimes the same conditions in human medicine is called something different in veterinary practice, which probably doesn't help to try to align some of the collaborations, because people are not naturally thinking about it. But I was quite interested in terms of the use of the hyaluronic acid for the tendinopathy in especially horses. Obviously, I'm familiar more personally with that as well. But do you think there's any specific reason that hasn't actually picked up in human medicine?
I suspect because we haven't thought about it. I think what happened in human medicine was hyaluronic acid was introduced as this wonderful thing that you could use for osteoarthritis, and it was going to delay how many people went on to get joint replacement surgery, or it would be great for osteoarthritic pain. But unfortunately, it's proven a big flop in human medicine, and the evidence base for hyaluronic acid is actually very poor. And so the NHS, being cash strapped and evidence driven, dropped hyaluronic acid for intra-articular therapeutic purposes a long time ago. Now it's fascinating, if you go into Europe, on the European side, you see it used a lot more commonly. So even then, evidence bases are interpreted differently. And I think, like most things, it's the phenotyping and the selection that's the problem. I have little doubt that the right patient with the right stage of arthritis in the right joint probably would benefit from hyaluronic acid. But when it was just being used in everybody, no matter how bad the joint was, unsurprisingly, it didn't work out very well. But because I think it got dropped for that indication, it just wasn't looked at for any other indication either. So I think that's the primary reason that I think most of my human rheumatology colleagues, when I say, well, in veterinary medicine, we use it in tendinopathies, they just go, you what? They've got no idea. So there again, I think that's why there should be much more collaboration.
Yes, and I suppose there's a similar problem on the PRP side, where it has been so overused for so many things, certainly in the human medicine. But I think it is still quite popular in the veterinary field in terms of different treatment options, especially for many of the joint diseases as well. You had some really interesting suggestions for collaboration, which will definitely something to build up on. And I'm hoping, and Joe will forgive me if I slightly jump the gun. So we are hoping to obviously have what we're going to be referring to as connection awards. So obviously those people on the two sides of the divide actually will get an opportunity to come together, because obviously it's quite tricky with all the day-to-day pressures of clinical practice, especially if you then have additional academic and teaching pressures as well, for people to give up the time to come together, and without having that, it would be impossible expectation. I'm going to ask you a slightly different question, which obviously you coming at it from a slightly different perspective because of your background as well, and because your family members being involved in different sides of the medical field. We often hear when we speak to people that, especially when you're talking to human medics and you say something about specific conditions in animals, they'll go, well, do they get that? Well, it's just a dog. So why would we care about that? Which is the sort of like, it's quite hard to get somebody with that sort of an attitude to engage in any sort of collaboration if it's just a dog to them. What would you, and I'm putting you on the spot here a bit, what would be your message to an individual with that sort of an attitude as to how that just a dog could actually help with their work?
I think you'd have to pitch it at their level. If they think it's just a dog, you're not going to change their mind on that. So I think the way you would come at it is it might be just a dog, but if you can use a spontaneous animal model to advance understanding for human disease and therefore get human benefits from it, then this is worth doing. Or if you can use an animal model, a spontaneous animal model, to find the next fancy cytokine, to be able to generate the next fancy, expensive biologic drug that a big pharma company will want to pick up, that's probably where you're going to develop the interest. If someone truly thinks it's just a dog or a cat, you're not going to change that. So I think you need to bring up these potential collaborations and where you can see the advantages for both.
No, I think you got it's a good point. They have to be able to see the benefits from a different perspective. Okay, I don't know if anybody, Joe, did you want to ask a question? Because you sort of unmuted yourself in readiness. And then...
Yeah, no. I didn't want to ask a question. I was just going to answer one of your questions, Helen, which was, can I collaborate? And the answer was quite simply, yes, please do. Because we need more people like you to be involved with helping us to drive that collaboration going forward. So yes, as much as you can do for us, we'd be very, very grateful. And I'm sure we'll come up with lots of ideas.
Okay, so is there, I don't know if anybody has any more questions.
Fabulous.
So I'm going to obviously be recording the presentation and it will be available. It will be available online, and there are quite a few people who have already expressed interest in potential collaboration and who will be sent a direct link to your presentations, which I can see at least for one of them 2 or 3 suggestions which they would love to chat to you about pretty much tomorrow if it was possible. Obviously it probably won't be, but it's definitely a lot of potential, and it's been a really great presentation. So thank you very much, because it's been really great to see the examples, and it's always astounding when you put the imaging, the x-rays next to each other, how actually at the initial look you can hardly tell what species you're looking at. And it's absolutely
yeah. In fact, it's one of my ones. I'm a bit naughty. I teach regularly pain clinicians as well. I teach a wide variety, but I will often put up at the end, one of the ones I'm always asked to talk is differentiating degenerative from inflammatory disease. I have a slide, I'm very naughty, at the end, having taught them the difference between inflammatory and degenerative disease. Here's an x-ray, which one's degenerative, which one's inflammatory. And one of the ones I put up is a dog paw with the rheumatoid arthritis on it. And I asked them, what's the joint? And they'll tell me quite correctly. Is it inflammatory or degenerative? They'll tell me quite correctly. And then I say, what's wrong with the x-ray? And I've only ever had one spot. It was a dog paw, not a human.
Brilliant.
That's a great example, because I think especially when you're looking at them, and even when you're looking at the spine, I mean, it's virtually impossible to actually tell unless somebody tells you, especially if you're just looking at the segment of the spine, it's impossible to tell which one is which. So it's and
I'm fascinated to look at more about the sacroiliitis. That one fascinates me. I'm sure you have inflammatory sacroiliitis out there, but it's probably not been looked for. So yeah, lots to work on, and I'd be very happy to speak more about the EDS, inherited connective tissue diseases, at any point if anyone's interested, or say the pain and the pain collaboration is where I'm more often talking, and the CRPS and things like that. So all of these, love to do some more with.
Brilliant.
Perfect. Well, thank you very much. It's been really a great presentation. I really enjoyed it. And as always, I've learned a lot. It's a privileged existence when you continue to learn.
Absolutely. Thank you so much for your time, Helen. We really, truly appreciate it, and have a really lovely weekend.
And we'll let you get back to your busy clinical work, no doubt.
Thank you very much.
Thank you, Helen. Thanks, Eva.